Hello, everyone. I think you'd be very interested in a rather unique session new to this conference this year entitled Health Equity, Better Access to Care for All. With me today is Dr. Robin Urquhart, who is an associate professor in Canadian Cancer Society Endowed Chair in Population Cancer Research in the Department of Community Health and Epidemiology at Dalhousie University. Dr. Urquhart is going to share a presentation with us that explores some of the current barriers to access to cancer care in this country and some of the viable solutions also to improve patient and health system outcomes. So without further ado, I'm going to pass you over to Dr. Urquhart, who has a brief presentation, and I'll come back and we'll have a brief conversation together after that. Dr. Urquhart.
Thank you, and thank you for having me. So I'd like to speak today, just for around 10 minutes or so, about what we know around health equity and cancer in Canada. Before I do that, I would like to acknowledge that I live and work on the ancestral, unceded, and unsurrendered territory of the Mi'kmaq people. All of us have a responsibility to continuously educate ourselves and work in solidarity with Indigenous communities, and we are all treaty people. I also recognize the histories and contributions and legacies of the African Nova Scotian people who have lived in Mi'kma'ki for over 400 years. So I thought I'd start, or I'd begin, I guess, at my beginnings. So I grew up in rural Newfoundland. You may see on the north part of Newfoundland here, if my cursor shows the White Bay. And so I grew up in a little tiny community right here called Westport, but that was largely isolated from largely an isolated outport community. And so when I was born, I am right here at a cousin's birthday party, chewing on a balloon. I'm probably about 1 year old. And when I grew up in this part of Newfoundland, we had really only just gotten a road access to our community about 5 years, 6 years before I was born. So it was still a largely isolated outport community. So I grew up in a community and with family, who, like the rest of Canadians, had health issues, developed cancer, and experienced a lot of challenges accessing care, based largely, I would say, on our geography, absolutely, but also based on things like low socioeconomic status, and so on. I also grew up, and I think this is important to mention, I was the generation, I guess, that grew up with, federated universal healthcare. So, the notion of universal healthcare in Canada started in the provinces, but really it was, the Canada Health Act in 1984 that harmonized our healthcare system, or our universal healthcare system. And, as I'm sure everyone knows, this healthcare system, it's not a national system. I mean, really, it's delivered by provinces and territories, but it is subject to national standards. So we do have this publicly funded system where people are assured of receiving, hospital services and physician services. So that's our core system, hospital and physician services, that are free at the point of care. So are free when we access those services. And the principles behind, universal healthcare is really that access to healthcare should be based on a person's need in our country and not on their ability to pay. And that really was a founding principle of the Canadian Health Act. And I think this is important to point out, because I think that many Canadians, or my experience is that many Canadians do feel that everyone in our country has similar access to healthcare, and that, they'll receive the healthcare that they need when they need it. And I also think that, many Canadians are, until, they may not grasp, I think, the shortcomings of our healthcare system, until they're diagnosed with a very serious condition like cancer. And one example is shortcomings around pharmacare, around medication use. So until you are diagnosed with a cancer, or a loved one is diagnosed with a cancer, that requires, oral chemotherapies that then you're expected to pay out of pocket or find some other way to pay them, we don't sort of recognize fully the what universal coverage means and what it doesn't mean. So I did want to say that because I grew up in Westport, this tiny, tiny community. Again, lots of cancer around me. And both of my parents were diagnosed with cancer in their mid-30s when I was growing up in this community. Both died of cancer in their 30s. And we experienced, I was a kid at the time, obviously, but they experienced very significant issues in terms of access to care. In fact, the nearest cancer center for my parents was 7 hours away in St. John's, Newfoundland, right here, 7 hours on a good day with a good drive. And it was challenging to get there, particularly for parents who, worked and had young kids at home. And so this is the context behind, I guess, much of my career and sort of my passion for understanding access and inequities in cancer. Trying to go to the next slide here. So today I work I live, I work in Atlantic Canada. I'm sitting here today in beautiful Mi'kma'ki, which is otherwise known as Halifax, where the setting with respect to healthcare and respect to sort of our setting, our demographics is a lot different than other parts of the country. And so I want to point these out. Not a lot of people live here. You can see these population estimates from last year, 2023, but not a lot of people live here, yet we had to deliver health services to all of these people. A lot of people who live here live in rural areas. That's really different from the rest of the country. And so if you take all of Canada together, about 17% of Canadians live in rural areas. If you look in Atlantic Canada at the 4 provinces, anywhere from 40 to 54%, depending on your province, actually live in rural areas. Again, challenges with respect to accessing healthcare. 22% of our population are 65 years of age or older. So again, implications in terms of developing cancer, because age is, one of the greatest risk factors, the greatest risk factor for developing cancer. And I think really important to point out is that most adults in Atlantic Canada, again, these are 2023 data, so from last year, but most adults in Canada are less than $200 away from insolvency. So 60% of adults in Atlantic Canada. That means they're $200 away from actually paying their debts on time. I personally find that to be sort of a tremendous statistic to describe our economic status, I guess, here in Atlantic Canada. And if we wanted to talk about colorectal cancer in particular, many of you will know that colorectal cancer, we have amongst the highest rates in our country, particularly in Newfoundland and Labrador. And this is just a study or a graphic from a study that was published in 2018 that really showed what I'll call sort of this gradient from the west to the east in terms of modifiable risk factors for colorectal cancer. So things like excess weight, physical inactivity, alcohol consumption, diet, and so on. And you can see here that in the north, as well as in Atlantic Canada, we have the highest risk factors for colorectal cancer. So there's a lot of things that are a little bit unique or a little bit different in Atlantic Canada that I think are actually really important in the context of cancer care. So now I want to turn to equity considerations and to think about equity for the next couple of minutes. So obviously, cancer impacts all of our population, right? Like it impacts everybody. So I imagine nearly everybody who's listening to this presentation, watching this presentation, has been personally affected in some way by cancer. We also know that the burden of cancer in Canada is not equally shared across sort of subgroups or across groups and across populations. So many people in Canada and many groups face barriers that lead to inequities in their care and inequities to accessing care. So we know that certain groups have a what I'll call a disproportionate cancer burden compared to other groups. And that's because of their social situation, their economic situation, their circumstances, their demographic circumstances, and so on. So there's a lot of evidence in our country, and that's a growing evidence to show that people who are from marginalized communities, for example, experience higher cancer mortality, so they a higher cancer death, and are diagnosed with more advanced cancers than other people. And so this is something that's concerning. There is, I will say, there is quite a bit of evidence now in our country that, and much more recognition that cancer among First Nations, Métis, and Inuit people is a really significant health concern. So we see a rise in incidence amongst Indigenous people. We see later stage diagnosis, and we see poorer survival rates between Indigenous people and non-Indigenous people in our country. There's also evidence that many people, when they develop cancer, are not served that well by our cancer care systems and our programs. So, for example, research has shown us across the country that where a person lives, their cultural and their ethnic background, their education level, their income are all associated with inequities in access to care. And that those are inequities right across the cancer control continuum that include things like access to cancer screening, diagnostic delays, so timely access to diagnosis, and then access to cancer treatments. So I've done quite a bit of colorectal cancer research. I'm a health services researcher. And my research in colorectal cancer here in Nova Scotia has shown inequities in access to both chemotherapy and radiation therapy in Nova Scotia based on how far a person lives from one of our cancer centers, based on their age, and based on their sex, so their sex assigned at birth. So we see inequities in access. So it's not, when I say inequity, I don't mean unequal access, actually. I do mean there are differences that should not be there based on a person's need. We've also shown in Nova Scotia that access to palliative care for people who have died of colorectal cancer is inequitable. The quality of their palliative care and their end-of-life care in their last months is inequitable, again, depending upon where a person lives in our province and their age in particular. There's a recent study that I read maybe a year ago now, out of Ontario, that found that people, again, with advanced GI cancers, so colorectal was in there, who experience poverty and unstable housing are much less likely to be seen by an oncologist once they're diagnosed with cancer, and much less likely to receive cancer treatment. So in other words, there are geographic, there are social, there are structural, there are financial barriers to accessing cancer care in Canada, even in the context of a universal healthcare system, even in this context where our entire healthcare system is supposed to be based on this idea that people will receive healthcare when they need it. And so I put this graphic up here. Essentially, for many people, I think for everyone diagnosed with a cancer, or for most people anyway, diagnosed with a cancer and or facing a cancer diagnosis, there are times when it feels like an uphill struggle. There are times when it feels really hard, and it's very challenging. But for some people in some groups, it really feels like they're trying to push a solid cube of a hill compared to people who may be given a sphere, which is just, a little bit easier. And that's often because of structural barriers and systemic barriers in our system. So what do we do? So one of the priorities I will say, so this is recognized within our country by our cancer systems now and by leaders in our cancer systems. And so one of the priorities of the Canadian strategy for cancer control is really to eliminate barriers to people getting the care they need. So they have a particular focus on making sure that the care that we provide across our country is adapted to the specific needs and the specific circumstances of different groups and different communities and of underserved groups and communities. Also, a big emphasis on making sure that people who live in rural and remote communities have the resources that they need to better serve their citizens, to better serve their people. And so I think I'll end here, but I mean, really, better care for access to all, and that was the title of this session, will really mean that, means we're all a piece of the puzzle. It's not just about cancer system decision makers and clinicians and physicians and researchers like myself sitting around the table. I think and developing solutions. So I think all expertise is integral to shaping our systems in ways that meet people's needs. All expertise is important. It needs to sit at the table, if I were to say it like that. And I think solutions have to be co-designed if they're going to meet specific and unique needs of different regions in our country, different populations, different communities. And they have to be delivered in ways that mitigate stigma, that mitigate bias, and that are culturally safe, certainly trauma informed, and that are welcoming and respectful for all people in Canada, again, regardless of their circumstances. So I'm going to end there. Thank you very much for listening. My contact information, my email is there, and I know we're going to have some questions. So I'll stop my screen share.
Thank you, Dr. Urquhart, for taking a very complicated subject and making it very simple to understand. The work you do is extraordinary, and to take that down to a 15-minute conversation, I'm sure, was a very challenging thing to do. There's a concept here I want to make sure that our audience understands, and I'm going to get you to speak very briefly about the difference between access to cancer care and the provision of quality care. Those are two different things, and maybe I could get you to comment and help people understand that.
Yeah. So I think about it like this. So I've studied issues. It's funny, I started my career studying access and quality. And for most people, if you think about entering the system, it all seems the same, I'm sure. Like I'm speaking in a very academic mind, right? And I'm thinking about these things and I measure them differently. But when I think about access to care, I think about, are people getting care? So something's happened. Maybe people have symptoms of a cancer, right? Are they getting care in a timely way? So as a researcher, I could measure wait times as an example, right? But also, is that care equitable? So, or are they experiencing, or are certain groups experiencing inequities in care? So I could map out Nova Scotia. I could look at the different regions. I could look at people's circumstances, their demographics, right? Their cultural and ethnic background, their language, really important. I could look at where they're living, really important. And I can actually look at whether they, and in a timely way, are getting access to diagnostic tests, for example, that would be a simple example. Quality, though, is okay. So the care that they're getting, is that actually the best care? Is that the care they should be receiving based on the best available evidence? So if they are diagnosed and then they go see an oncologist, the care that they receive at that point, for example, the chemotherapy they get or the radiation therapy, is that actually best practice? Like, is that the best care is that the care we're supposed to be giving people based on what we know from the evidence? And what we know means, mostly means based on, survival advantage, right? Or, the sort of chances of surviving your cancer, but also based on what we know around side effects, toxicities, like things like that, right?
Yes.
At quality of life. So once you get in, are you getting the care that's actually the best type of care you should get?
Yeah, thank you for drawing that distinction. I think it's quite an important conversation. Now, before we open it up to the audience for the many questions I know we're going to have, I wanted to touch on a point that you raised around, the concept of it's going to take a lot of people to drive positive solutions that have positive outcomes. I think there's a thought here, well, it's someone else's problem, it's the researcher's problem, or it's the system's problem. But you talked about the idea of many people involved. Particularly, I'm interested in your views on how patients or people with cancer, people with lived experiences need to be engaged in this conversation.
So, oh goodness. I think the conversation should not be happening without people with lived experience. If we're trying to address and redress inequities in care, I will say that, how can I, as a white woman, highly educated, high income, living in an urbanized environment right now, literally I'm 15-minute walk from the main academic tertiary cancer center in Halifax. how can I, if I'm designing a system, understand what it is to access care if I am living in poverty. I don't have an insurance program. Maybe I'm in a cash sort of based job. Maybe I've struggled with mental health and addictions for the past 40 years. Maybe like that's those experiences are completely different. Let's say I have been marginalized. I have experienced structural racism, systemic racism through my education, through my workplace, through my healthcare system, the healthcare system that I've entered when I enter it. And so how can I sit down? How can someone like me sit down and understand what's best? And understand, I can't understand that experience, but I also can't understand how the system needs to be designed to provide the care that's needed, right? And so
Right.
I don't actually think I don't think we can anymore design systems and programs and services without including people with lived experience. I don't know,
Yeah.
did I answer your question?
No, you answered it beautifully, and I think it's a wonderful bridge into our Q&A session where I know that many audience members might be interested. Well, how do I put my voice at the table? What are those things that I can do to improve what is a very challenging circumstance? So with that said, let's move into the Q&A.
Thank you.
Well, thank you, Dr. Urquhart, for staying and answering what I know are dozens of questions coming in on this very, very important topic. And we're just going to have another dialogue here. And I want to say to our audience, please keep those questions coming. We love them. Anything that we don't get to answer as part of the brief session that we have today, I promise you that the team at Colorectal Cancer Canada will be reaching out to you to ensure that you get the information you need. So let's go to one of the very first questions here. I'll read it out, Dr. Urquhart, and then we can unravel it a little bit here. What improvements have occurred in terms of equitable access to quality screening, treatment, and cancer care? So I think the nature of the question is that, the trajectory over time, certainly with all the energy that's gone into health equity, things have improved. What are some of the, let's call them wins, improvements?
Yeah, so I think that there have been. I think we still have a long ways to go because this is not going to happen overnight, right? We're not going to have equitable access to care overnight. But I think there's some key initiatives. And so I think about cancer screening as an example, and even cervical cancer screening. So there has been, and there continues to be, I mean, it's a rather new sort of focus, but here in Canada, I mean, but in terms of HPV testing and
Yes.
making, so this new technology that really makes cervical cancer screening a bit easier for people and definitely more accessible. And so I know there have been efforts, particularly in some of our Western provinces, and we're doing some work now in Nova Scotia to sort of lay the groundwork to improve cervical cancer screening in terms of the accessibility and so on. So HPV testing is something that you can do at home. And we think about FIT testing for colorectal and so on. And there's a lot of work, I think, to be done across the board around improving access to screening and equitable. But I think there have been a number, and I am thinking about HPV testing. There's a new technology, and there are a lot of people in this country working particularly in rural and underserved communities, in many Indigenous communities to improve access to cancer screening. But this is one example, one technology around HPV screening.
Yeah, that's taken a lot of profile recently for sure. And so would you say
Yeah,
the technology that really has improved that access to it,
it has. It's
notwithstanding
also,
some of the policy issues?
I think it's also it's recognized, like there are certain cancers out there that are largely preventable, and cervical cancer is one of them. And so if we live in a world, if we live in Canada, which, arguably you can say, I mean, would have a world-class cancer system, well, we should be able to figure out how to prevent those cancers that are almost entirely preventable, like cervical. But lung is another example as we roll out high-risk lung cancer screening programs in our country, and different provinces have done that. There has been a lot of work looking at how do you ensure that people have access to those programs, and even things like mobile screening with and so on in different, again, often rural and underserved communities.
Yeah, can I build on that, because that's really it's a leverage off a great question here, which is about the practicality of navigating issues when people do live in rural areas. I think that it's known that if you're in a rural area, access is an issue, equity is an issue. What are some of the practical ways that people can think about navigation for improved access if they are indeed in a rural area? What should they do?
Yeah, I'm from a rural area, and this is something that does actually keep me up at night thinking about how to improve access we're a very rural, we're a very big country in Canada. I think some of the practical things. One is I do think, unfortunately, we still have issues in our country with internet access and so on. But I do think that the pandemic has opened up some opportunities there in terms of virtual access to care. I think we have technologies coming down the pipe. One of them is HPV screening from a screening perspective, but also a lot of technology coming down the pipe around, let's call it liquid biopsy, for example. Yeah. And so we are getting to a place now where people, and we are trying to build those structures as we develop the technology, where people may have access to, as an example, liquid biopsy, or, most commonly that would be a blood biopsy, a blood draw. At their local community hospitals, instead of having to drive 3 or 4 hours to get imaging or to sort of a specialist center. And I think the other thing is, so I work in Nova Scotia. A number of years ago, the Nova Scotia government implemented some added sort of support programs for people, particularly who live in rural communities. And so a lot of those was support programs around transportation costs and covering cost of accommodation, and so on, if you have to travel, but also have put a lot of money into support services in the community. So the oncology providers, specialists might not be there, but we have more social workers, we have more nurse practitioners who specialize in oncology. And so I think that that is one way to sort of build capacity in rural areas. So it may not be about the newest technology, the newest radiation suite, but it is about helping people and having policies and programs in place to help people to be able to access those. And one of the problems around access is affordability and needing to take time off work, and needing to travel, and so on.
Right, yeah. Right. So if people are in a rural area and they want to access some of these, what I call enhanced resources that have been put in situ, how would they do that?
So it's going to depend on the province, obviously, because our healthcare is largely provincially based, with the exception of a few programs. And so it will depend on the province. Some provinces, through their cancer agencies, provincial cancer agencies, do have programs or equivalent. Not all provinces have provincial cancer agencies anymore. There's been a lot of change in that regard. I understand that. But the reality is, across the country, there are a lot of people who work in navigation roles, whether they're cancer patient navigators or maybe drug access navigators and things like that. And those people are wonderful resources. I can't tell you how
very good
resource they are, and they know about these programs. They can help people access them. I also think there's a big role there's a lot more sort of patient advocacy organizations that have more expertise in sort of navigating those sorts of programs and services.
Yeah, and that's a great bridge, Dr. Rickard, to a question here, which is really about how can marginalized groups advocate for better access to cancer treatments. Certainly groups like Colorectal Cancer Canada are part of that. But, just some groups that may not have direct access to patient group organizations or more remote, et cetera. What should what should some of these groups do? What are the key points that they need to be making?
Yes. So how do I say this without sounding so like it's important to have their voices heard. So there are groups that may be underrepresented and are certainly historically marginalized and different communities right across our country. Um, there's also a lot of strength and resilience in those communities. And so let's build on the strength and resilience. And people do, I think those communities do need to sort of um, you know, well, so I'm going to flip that around. I think that those communities need their voice heard, but I think it is sort of people in more privileged maybe positions, and I'll speak as like an academic here who, has a PhD. And so I am a very privileged person. And so I think part of my responsibility to to like Canada and to communities is to use that privilege actually to help communities that may not have the same level of privilege, but certainly have so many strengths and so much resilience. In fact, I think we could learn a lot from underrepresented communities because of the resilience that exists there. And so I think that, what can folks do? I think there should be a responsibility actually on some of those folks that have and communities and folks and groups of people that have more power and maybe can advocate as well. I feel like it comes both ways. So I'm thinking back to a conversation I had very early in my career, and it was actually around gender imbalances in academia, in leadership roles, and so on. And I remember sitting at this table in an academic setting, in a leadership setting, where there was, a couple of women and folks who identified as women and a lot of men. And I left that. And I left with a colleague of mine, sort of a former mentor, and we were walking. This is in Halifax, so we're walking home together. That's how small Halifax is. And I said, it's not just about my voice though. And like, as somebody who's representing women, it's like, you need to do something. Like, you need to actually be able to help us shift the power, right? As a man in a leadership position in a medical, in medicine. And so I think that, I think there's sort of the, I, I think that, yeah, I think it comes from both ways and all over. Yeah.
I think that you are an incredibly powerful voice in health equity. We thank you so much for being part of our conference. We've tried to tackle a very big subject in not a lot of time, and we'd love to invite you back for more conversation in this space. So many, many questions still on the roster here. We'll try to get to all of them, but thank you so much for taking time in your day to come
Thank
and
you.
share your expertise with us.